Hi, welcome to Season 2 of KidzDocTalk with Dr. Jennie. Our guest today is Dr. Sarah Becker, talking about child and adolescent mental health. Dr. Becker is the co-chief of child and adolescent psychiatry at Zucker Hillside Hospital at Northwell Health in Long Island, New York. She completed her medical training at Albert Einstein College of Medicine, where she was selected to join the prestigious Alpha Omega Alpha Honor Society. Dr. Becker completed her training in adult psychiatry at Montefiore Medical Center and received a degree in pedagogy from the Ministry of Education in Israel after completing her studies at Beth Jacob of Jerusalem. Her clinical interests include the treatment of management of eating disorders. Welcome, Dr. Becker.
Welcome to KidzDocTalk with Dr. Jennie. Dr. Jennie is a board-certified pediatrician and is the director of telemedicine at Pediatric Associates.
Hi, Dr. Becker. Thank you so much for joining us.
Thanks so much for having me.
So I'm really excited to speak to a psychiatrist, and I want to just start off right off the bat and tell us a little bit about what is the difference between a psychiatrist and a psychologist. What types of things does a child psychiatrist actually deal with and take care of?
Yeah, so that's a great question. And it's a very common misconception or kind of not clear to people what the difference is. So let's start off with what the difference in training is, and then we'll kind of get to, how that maybe translates to differences, in practice. So a psychiatrist is a medical doctor. That means that they either went to MD medical school or they have a DO, right? So they went to osteopathic school of medicine. And so that means that they can practice medicine like any other doctor that you might see. So, you're a pediatrician, you're an internal medicine doctor, you're a rheumatologist, right? A psychologist goes to a different type of school, and they will get either a PhD or a PsyD, depending if their training was more kind of research focused or maybe more clinically focused, clinically oriented. A psychiatrist, because they're a medical doctor, that means that after they complete medical school, will go through a residency. And then if they would like to become, specialized, so for example, I'm a child and adolescent psychiatry fellow. So then you'll do a fellowship, which is additional training after residency. A psychologist, as part of getting their PhD or PsyD, will do clinical years in that program. So first they'll be an extern. So some people, maybe listening to this are being treated as part of a school-based program, and they maybe have a therapist who's either an extern or an intern, which is more advanced than an extern. And then after they complete their PhD or PsyD, then before they can get licensed, they're going to do one more year, which is called a postdoc. And then after that year, they're eligible to, take their licensing exam and apply for their license. So that's the difference in training. Then because they have that difference in training, their scope of practice is going to be different. So the number one most obvious difference is going to be that a psychiatrist prescribes medication, and obviously a psychologist does it. Now, when it comes to other forms of treatment, that actually is a little bit more nuanced, right? So people typically think like, only psychologists maybe do psychotherapy, but actually a lot of psychiatrists, as part of their practice, because, do psychotherapy as well, because they got psychotherapy training as part of their residency program after they finish medical school. A big difference that psychiatrists do not do, that really only psychologists do, is the neuropsych or psychological testing. So these are kind of like batteries of exams that some people might need for learning disabilities, or, to diagnose a learning disability or some other deficit, or maybe to diagnose autism, things like that. That would be something the purview of a psychologist that a psychiatrist would not typically do.
Okay, so it sounds like there's probably a lot of overlap between what a psychiatrist like yourself and a psychologist would be taking care of. So can you give some examples of things that a typical, some typical conditions that a child psychiatrist treats and takes care of?
Yeah. So a psychiatrist, I think, for a child psychiatrist, probably the number one diagnosis that I see is ADHD, attention deficit hyperactive disorder. And, that obviously can be managed both with medication, which commonly ADHD does require medication to manage optimally. But there are also behavioral techniques that we want both the child to incorporate, the parent to incorporate, the teacher to incorporate, to help the child perform, at his or her best. After that, I think it kind of splits up evenly, seeing some children with depression, different types of anxiety disorders. So you have generalized anxiety disorders, and then more specific ones where they're specifically afraid of something or specifically afraid of a certain situation, or social anxiety, panic disorder. Those kind of all fit in the rubric of anxiety. And then there are things that maybe are a little bit less common, but still, prevalent, like OCD or tic disorders. And then there are things that I would consider more rare, or things that, obviously we see, but are not as common, and that would be things like bipolar depression, or some people call it bipolar disorder, things like psychosis, are other, things that we treat in the outpatient setting. Sometimes, we get called in the hospital to treat things or to help diagnose things like conversion disorders or factitious disorders. And, those are situations, what I try to explain to parents and children is that's a situation where you're having a bodily symptom, but it's coming from a psychiatric cause, right? It's coming from your mind. And so we try to help, parents and patients understand that as well, and help the medical team deal with that as well.
So you mentioned anxiety and depression, and, as a general pediatrician, I feel like I'm seeing more of that now than ever, and we can get a little bit more into that. But a lot of times I find that, parents are surprised by that diagnosis. So are there different things or different strategies that parents and caregivers can use to identify or realize that their child might have depression or might have true anxiety beyond what's sort of like typical for the age?
Yeah. And I think that's a big role of what pediatricians do as the gatekeepers, right? Trying to help parents separate what is kind of normal or normal variance, and what needs extra help and extra attention. I would separate depression and anxiety when we're kind of talking about this, because there are different disorders in that depression is something that we call episodic, and I'll explain what I mean by that. And anxiety is typically what we call more lifelong. And I'll explain what I mean by lifelong. And, people might hear that and get nervous. Oh, this is something I never get over. And, but I'll explain what I mean by lifelong as well. So when I say depression is episodic, that means that the nature of depression, the way it works, is that it comes and goes, right? Is that people, and that's even the definition in the DSM. So the DSM-5 or the is kind of, people make a joke, it's like the Bible for psychiatry. But what it is right, it's a compendium of different diagnoses and what the criteria is for diagnoses. And so sometimes if you go to a psychiatrist, they may refer to the DSM or DSM-5, to say, oh, it does, your child does meet criteria for this diagnosis or doesn't. And that's what they're talking about. Okay. And so, when it talks about depression, it talks about this, that, you're sad or down for at least 2 weeks at a time, could be longer. But the idea being that it's something that happens for distinct periods and then it goes away, and then it might happen again. So when parents are looking for depression in their kids, really what you're looking at is there a change, right? Is this a change from baseline? I used to have this happy-go-lucky child, and all of a sudden, something is different. Now, something really important for parents to know when looking for depression in their children is very commonly in children, depression does not present as sadness. It is much more common, especially when we're talking about teenagers, that it presents as irritability or anger. right? All of a sudden, the kid is slamming the door, it can't stand anything, right? And sometimes it's useful to have a frame of reference, comparing to, teenagers get moody, but is this the same as my other kid who is moody, or is this the same as the friend who is moody? So it's sometimes, important to use kind of a frame of reference. The other thing is it just irritability? Is it just anger? Or are there other things happening as well, right? Is it this kid can't sleep, or it sleeps too much, or something's changing in the eating, or something changing in their energy level, right? So you're looking kind of for maybe more than one thing happening at a time. And if you're seeing those things, it's definitely time, the first stop, I think logically, is to talk to your pediatrician, right? Because the same way that your child from birth, likely you've seen your pediatrician for a long time, they know your child for a long time, and they also have the benefit of all the medical knowledge and medical training that they have. And so having that conversation with your pediatrician to say, is this something we should get looked into? Is this something we can need extra help? Is a great first step. I'll also put in a plug for I know that's what you do, but I'll put in a plug for pediatricians to say that most psychiatric conditions are actually not treated by psychiatrists, right? They're treated by, primary care doctors. So a lot of pediatricians are very capable of taking care of, I don't want to call it easy, but, cases of depression, cases of anxiety, cases of ADHD. And so definitely going to your pediatrician as a first stop is a great idea. Before I go to anxiety, I don't know, do you have any comments on the depression?
No, I think I'm curious to hear how anxiety and how that diagnosis is different. But I think the big scary thing when parents hear that as a potential diagnosis, even coming from a pediatrician, is, well, obviously maybe, not expecting it, and all the scary things that go along with what they perceive the treatment involves. But I feel like a lot of times the question is this a forever diagnosis? And I know you said you were going to talk about and mention the difference between something that's episodic and lifelong, but is this a thing that you sometimes see kids grow out of, so to speak? Or once you have a diagnosis as a young child or a teenager, you're kind of stuck with it and you sort of just manage it?
So that's a great question. Something like depression, and this is not just limited to childhood depression, this is depression across the board, right? Once a person has one episode of depression, okay, so again, lasting at least 2 weeks, but if untreated, can last months and even over a year, right? That's why we want treatment. So we shorten these episodes. And then, you work with your psychiatrist and you say, okay, well, now the depressive episode is over, how long do we want to continue maintenance treatment for? Once a person has one episode, is it possible that they could have another one? Yeah, it's possible. And some people will have one episode and it will never happen again, right? Some people, once, let's say maybe you had, more than one, maybe two, maybe even three depressive episodes, right? Again, distinct periods of sadness or irritability or, changes in mood happening, then yes, it becomes more likely that this could happen again in the future. The good news is that this is a very treatable condition, right? There are medications, what I tell people, and I'm sure we're going to get kind of to treatment choices a little bit later in the talk, but what I tell people is that antidepressants are really well-tolerated medications. The ones that we have these days, which have been around since the 90s, okay, are medications that are really well-tolerated with few side effects by kids. And so if they need it, then we give it to them because we want them to do well. There are definitely cases where someone is going to have something in childhood and they'll outgrow it, right? Or they'll learn to manage it in a different way, right? They, that management may not be with medication. That management may be just, skills that they picked up with psychotherapy that, they had in childhood, or maybe they do again as an adult. So, I guess to kind of circle back, one is anything a forever diagnosis? Not necessarily. And even if something is a diagnosis that may impact you in different ways as, kind of life goes on, there are many different ways of managing it. And in no way does this mean that it needs to be something that impedes your child's life. On the contrary, right? Our goal as child psychiatrists, and what I tell everybody when I see meet a kid or meet a teenager for the first time, is my goal is for you to have a great life. And for you to think about this, whatever it is, this is ADHD, depression, anxiety, as little as possible. So you could just be a normal kid and do whatever you want to do.
I think that's really reassuring to hear that it's not like a forever stamp and not something that necessarily takes over somebody's life. That's the opposite of what you want, right? Your goal is to kind of have the child functioning at the level that they should be. So I really want to talk about treatment because I have so many questions, but let's talk a little bit about anxiety, right? So what are things that parents can notice, or what are things to look for to maybe indicate that the child is anxious, again, beyond, what is normal or developmentally appropriate for age.
Right. So, depression, if you remember when we spoke about depression, we said, this is something where we're saying you're noticing a distinct change in your child, right? This, my happy-go-lucky child went to, being this irritable, moody kid. Where'd my kid go? Anxiety classically, it doesn't mean everybody's like this, but classically, it's a temperament from when the kid is young, right? The kid is always anxious. The kid has always been a worrier. And then, the question is, well, when do I go get help, right? Because there are plenty of people with anxious temperaments that don't necessarily need professional help, whether that's psychotherapy or medicine, as the case may be. What I say is when the worrying is getting in the way of functioning, that's when you want to get help, right? So there are different types of anxieties. One of the classic types of anxieties that we see in younger kids is separation anxiety disorder, right? The kid just can't separate from mom. Mom can't leave the house. The kid can't go to school, right? It takes hours and hours to create a separation, right? That's a problem. The kid's not functioning, right? A child cannot healthfully develop right into an adult if they can't separate. Social anxiety, right? The kid, won't talk outside. That's selective mutism, right? When the kid won't talk outside of the home, but the kid is afraid to hang out with other kids, or it's constantly has this negative, ruminations, mental self-talk that they're going, I'm worried I'm going to say something dumb. I better not say anything, right? So, or generalized anxiety disorder, right? Like just worried about everything. Maybe something terrible will happen to mom. Like maybe I'll get into a car accident, right? This constant worry, and it's getting in the way of them doing what they need to do and functioning in the way that a child their age should be functioning. It's time to go, first stop being to your pediatrician to say, what do you think about this behavior? Do you think it's something that we need to do and take care of?
So I want to segue a little bit into treatment, and maybe the answer will be different for anxiety and depression. But should the first line, as a general pediatrician and as a parent, like what, from an expectation standpoint, should the first line be psychology evaluation to see if there's, behavioral modifications or what compensations we can think of? And then if they're really not improving after a certain amount of time, we escalate to psychiatry in anticipation of medical management? Or depending on how severe the initial presentation is it sometimes more appropriate to see the psychiatrist right off the bat?
Again, excellent questions. I think there are different variables here that will kind of guide you in one way or the other, and let me try to break it down. One is a basic availability question, and one of what the availability of the parent is, right, to be able to do it. Because a lot of these cases, I would say psychotherapy really would be very beneficial for these kids. And there are times where a parent will say, I cannot do weekly psychotherapy. This is just not going to happen. Or sometimes the house is kind of too chaotic, really, to really kind of put in place these psychotherapeutic interventions. Sometimes it's really hard to get into a psychotherapist. It might be easier to get into a psychiatrist than it is to get into, and I use the term psychotherapist because I want to include both psychologists as well as social workers and maybe other, mental health workers who are trained in psychotherapy. The other thing that I'll say is, whatever psychotherapy that you're doing is only as good as the psychotherapist, right? So you want to, a lot of times, I maybe will see children and I'll say, do you like your therapist? Yes, I love my therapist. So what are you doing in therapy? I don't know. Right. And so you want kids to be able to really be able to talk about what is it that we're doing in therapy? What are we accomplishing? Where, what modality, maybe the kid doesn't know what modality that they're doing, but you as the parent should know what modality, is the therapist using and what's the goal, right? What are the goals? What are we trying to accomplish? So those are just some, kind of, I would say, practical considerations that to keep in mind, even before we get to, what's the best thing. I think for something like ADHD, right, it makes sense to get to a psychiatrist earlier rather than later, because in all likelihood, the child will benefit from medication. And what I tell people is that our evidence for medication in working for ADHD is probably the best you'll get anywhere in psychiatry, right? These medications work. We know how to use them. They get great results with kids, and they some kids really describe it as like just being like not let loose, but able to achieve the potential that they know they can achieve, right? And I know some parents really have a lot of hesitations. Well, stimulants, and is it going to be addictive, and what's going to happen? But what I will say is that prescribed in the hands of a responsible psychiatrist who's watching it, the likelihood of addiction is very small. And actually what we know is, from some of those studies that were done in this population of, teenagers with ADHD, is that ADHD in itself is, can be a risk factor for developing a substance use disorder, and being on a stimulant reduces your risk of actually coming to addiction. So, parents are worried, if I put my kid on a stimulant, they'll get addicted, when in reality, actually putting your child on, giving them the medication that they need, reduces their risk. So that's for something like ADHD, where I think it's, much more clear cut that medication is the answer. For things like depression and anxiety, and I actually would separate that further between depression versus anxiety. I think for things, something like anxiety, really, the data supports, experience supports how important psychotherapy is. And again, that makes sense, right? Because we're talking about, that's how we said it, talking about something that's more lifelong, something more ongoing, right? It's something about a temperament. It's something the way people, interpret different situations. Having a psychotherapist who can readjust the way your child, makes decisions, your child views, situations as potentially dangerous or not dangerous, right? That's going to be really, really important. And yes, that makes sense to be the first stop, on the go round. Sometimes when you go to a therapist, they may tell you and say, I definitely could work with your child. I definitely think therapy is going to help your child. And I can just see that your child is so anxious that we're going to need to get some medication on board to kind of bring down that anxiety before we can really get to work in therapy. For depression, I think, again, right, remember these are episodic, these are episodes, right, that occur. I think it really depends, right? I think if, someone has really, your child has really severe depression, maybe not getting out of bed, not going to school, just no motivation, refusing to do anything. And I think it's also important, so, it's important and something that we ask about, right? Children also have suicidal thoughts, right? Children also think about, life not being worth living anymore, or wanting to die, wanting to kill themselves. And so, yes, those are situations when, you're having those severe symptoms. You want to be thinking about getting to a psychiatrist sooner rather than later. I think for more mild depression, right, it's completely reasonable to say, let's start with psychotherapy, right? Let's start with CBT, or let's start, with some other modality, see where we get, and then make a decision, maybe together with the therapist, whether we should, look at medication or not.
So I deal with a lot of medication hesitancy, specifically with ADHD, which I think you addressed really well about, the strong evidence we have with the use of stimulants. But what about medication that's commonly used to treat anxiety and depression? I think a lot of parents really struggle, I think, accepting that as their child needing it. What do you, Sarah, what would you say to those parents to sort of reassure them that this is appropriate?
I think I start off by saying, I understand where you're coming from, right? And, and I let people know that I'm a parent as well, right? And as a parent, we want what's best for our children, right? And we're always, I think, as much as we want what's best for them, we also want to do no harm by them, right? We want to make sure that we're not putting something in their body, right, that's going to cause long-term harm. And I think, especially when it comes to psychiatric medication, people are always worried, what is this going to do to their brain long-term? Is this going to cause some irreversible changes? And so I point out to people that, let's say the most common medications that we use for depression and anxiety, actually use the same type, are SSRIs, or selective serotonin reuptake inhibitors, meaning it works on the serotonin syndrome. And as I mentioned earlier, right, these are medications that have been around since the 90s. So we're talking about close to 30 years at this point. And, these have been well studied, right? And many, many children have been on these medications for years, right? Or in early childhood and have grown up by this point. And what I point out, and I think this is a really important thing when we're helping parents make a decision, right? Because this is shared decision making. We're not telling people what to do. We're trying to help people make the best decision that is best for them, their family, their children. Is that we're not making a decision between medicine and nothing, right? We're talking about things that impact their brain, right? You're making a decision between, giving your child medicine. And yes, there are risks. Anything we do in life has risks, but it's, are you going to give your child medicine, or you're going to leave your child with untreated depression and how that impacts their brain, right? And because, we know that untreated depression also, impacts your brain. We know that untreated ADHD also impacts your brain. And actually, we know it. There are, especially with ADHD, which is probably the kind of the thing that we see most clearly, let's say, on imaging, right? Changes in the brain, right? Untreated ADHD, there are changes in the brain that we see. Same thing with untreated, depression. You'll see it maybe more in what we call fMRI or functional MRI scans that can see how the brain behaves. Untreated anxiety, right? Not treating these disorders in the way that they need to be treated also has consequences, for your child. So I think setting it up to make sure that parents are really weighing both sides, right? It's not like, either I give medicine or nothing, but it's, well, I if the child needs medicine, I give the child the medicine that maybe their brain needs, or I leave their brain to kind of fend for itself with an untreated condition. That I think helps in terms of medication hesitancy and puts things in a different perspective.
I think that's helpful. And again, super, super reassuring to think about sort of sticking with this idea of parental hesitation. I also see a lot of almost like parental guilt, right? When I entertain the idea that child may be anxious and depressed, because I think a lot of times the initial thought is, oh my gosh, did I do this to my child? Or are they anxious because I'm so anxious, or depressed because, right, I'm depressed, or someone in my family is. Are there risk factors, first of all, for mental illness in children, or are there things that families and parents can do to so to speak, prevent mental illness? Because I want to sort of dissuade any kind of guilt that goes along with having that diagnosis for a child.
So I think the way that we think about the development of mental illness or psychiatric disorder, I don't know which one is less stigmatizing, but whichever one is, we have what we call the Biopsychosocial Model. And so that kind of takes into account someone's biology, someone's genes, right? Psychological aspects and social aspects. So let's go through each one. Let's start with someone's genes, because that's kind of the easy one to do. Now, this is not to say, one gene, one trait. It's not like there is one depression gene, one anxiety gene. But we know that kind of when people's genes interact, and maybe interact with some of the psychosocial part of the model, it can lead to expression of, depressive traits or anxiety traits. And there's definitely what to be said about, depression running in families, anxiety. Anxiety is probably the most heritable one, maybe ADHD as well, right? These are things that will run in families. It's like, oh yeah, I have anxiety. My aunt has anxiety. My grandmother has anxiety, right? Or, my cousin has ADHD, right? So these are things that run in family. I don't know, is it someone's fault? I have blue eyes because my parents have blue eyes. That's the way that, we're made. That's the genes that you got dealt with. And then sometimes it's, you put two parents together and maybe on its own, one had one set of genes, one had the other set of genes on its own, maybe wasn't significant, but it gets mixed up in the kid. And, that's enough to bring out the genetic side of it. So that's the biological side. Then there's the psychological part. When I say psychological part, what I mean, typically what we talk about is temperament, right? We refer to that, earlier on, right? So some kids just seem to, if you remember thinking, the parents listening to this, right? Some of your babies were just like so easy, so, whatever it is. Some of them were so uptight, they needed it to be exactly as it is. Some babies were, slow to warm up to new people. Some people warmed up, some babies warmed up more quickly. That's what we're talking about. We talk about a temperament, right? And that's kind of like a nature that will follow a child, kind of along life. Now, it doesn't mean, again, this is not set in stone. We're going to talk about other things that can kind of impact it, but that's like the nature that a child is born with. And then, a child learns from things around them, right? So, and we can change things, right? So, I think some schools are trying to teach more psychological, being more mindful of psychological principles. So kind of things like mindfulness, things like relaxation techniques, right? So again, all of these things go into psychological principles, or the opposite, right? Like kids who really can't figure out things or can't, cope with anything, right? So that will kind of go along with psychological. Then there's the social aspect, or the environmental aspect, right? So that is, the things that happen in the home, that is, a single parent household, a 2-parent household, blended family, that is, what happens to the kid in school that fits in with bullying, how's it working out with the teacher, what's the atmosphere like in the house, right? And so all of these things kind of coalesce into create environmental factors. So we put that all together, the biological aspects, the psychological aspects, the social aspect, and you have what we call the biopsychosocial model that talks about kind of the development of, in some cases, you put enough of these factors together, and so you end up with, fill in the blank, whatever psychiatric illnesses. I think what I try to have parents come away with is that there are so many things that, can come and impact a child, right? The genes, the psychological health, right? Just luck, what happens in the environment, to kind of take it on yourself and say, I caused my child to have depression. I caused my child to have anxiety. Sometimes I make a joke and go to the other end. I say that's actually hubristic, right? Like, what do you think? You think you're so powerful that you could make your child, have depression? And say like, there's a lot going on here. That being said, I think that there are things that we can be mindful of to build our children's resilience. And resilience is probably, kind of one of those like hot words that come up in psychiatry, right? Like that's, we want to talk about it. How do you build childhood resiliency? Talk about during COVID pandemic, right? Like how do we make these kids more resilient so that, they're not impacted by all these things going around them? I think step one is for parents is that, if you need your own help, then get your own help, right? If we as parents are, angry and irritable and anxious and, are overstressed, that's, of course, that's going to impact the way that we parent, and that's going to impact our children's experience, right? There's no shame in getting psychotherapy for, oneself if you need it. There's no shame in being on medication if you need it, right? If anything, that's a really brave decision to make, that you're doing something that will directly impact your child for the better. I think, having clear rules in the home, right? We're not talking about, authoritarianism, right? We don't want to be dictators in our home, but we talk about authoritative, right? That children need to know that there's someone in charge, right? That their parents are in charge, because that creates a certain sense of structure and safety. Even consequences, right? For a child create a sense of structure and safety. And I think we want to create, a warm, loving home where we can build up our children's self-esteem, right? We can focus on the positive things that they do, right? It's not just, you're, giving our children compliment, but constructive compliments, right? I think it's more than saying, you're so pretty, but it's, I love the way that you gave that wonderful compliment to your brother, right? Really kind of getting down to think about, what are things that we can do to build up our children, build up their self-esteem, and, build up their resilience. So I hope that answered the question.
It did. No, that was fascinating. I probably have like a whole lot more questions just on that, because I think resiliency, especially now, is so, like you said, like a hot topic, right? With the pandemic and having children sort of deal with a lot of new things that even adults are struggling to deal with. So in that same vein, you probably know, of course, better than me, that the AAP, American Academy of Child and Adolescent Psychiatry, sort of jointly declared a national emergency in children's health. So I mentioned earlier in the talk, as a general pediatrician, I feel like I'm seeing mental health issues more than ever, like astronomically more than ever. So let's talk a little bit about that. What do you think about this sort of call to action, this calling, this national emergency, and what is it that as parents we can do to kind of bring down this sort of situation that seems to be on fire?
Yeah, so I definitely agree that there is a national emergency. I mean, I'm part of a large health system. Our emergency room, our psychiatric emergency room, probably is at 150% capacity, right? We're just seeing more and more cases of children, so dysregulated. They're ending up again, in the behavioral urgent care center. This is going back. They're saying things like, I want to kill myself. I don't want to be alive anymore. Complete, behavioral dysregulation. And if that's kind of the worst end, right? If the goalpost for the worst end, most extreme end has moved, everybody else has followed with them. And, I think people estimate that rates of, mental health disorders in children, at least through COVID, have doubled, and so, yes, we are faced with a national emergency, because I think part of the emergency is the shortage. And this is what I was talking to you before about, saying, do I go to psychotherapy first? Do I go to psychiatrist first? Sometimes the answer is you go to who you can get into first, right? Because it's difficult to find, psychiatric providers in this landscape when there's just such a high demand. I think, I don't sit on the AAP. I don't sit on ACAP. I hope the national emergency, kind of declaring a national emergency, results in changes. But I also recognize that, there are only a certain amount of psychiatrists who are produced a year. There are only a certain amount of psychotherapists who are produced a year. This is a finite number. And so we need to be a little bit more creative in terms of, how we deal with it. Some things that have been changed is I think that there's a larger emphasis on doing things like group therapy, which we actually didn't even really talk about so much. We spoke about this kind of, individual psychotherapy, but there's actually a lot of good evidence for groups being very effective, especially when they're groups that are kind of teaching kids skills, right? Teaching kids like, how do you cope with stress? How do you cope with anxiety? How do you increase your frustration tolerance, right? And so groups we know are very effective, and that's a way to kind of get, one or two psychotherapists to, in a single hour go from reaching one kid to reaching like 15 kids, right? And so if that's something that's available to you or your child, then I would encourage people to consider that as a real mode of treatment. In terms of, what parents can do, I think, checking in with your kids, having honest and open conversation. And sometimes, right, like kids are not going to respond, sometimes, especially teenagers, right? Like, how are you doing? Good. Everything's okay, But I think having relationships with our children where they know that they can, tell us anything, right? Making time to spend with our children. I think one of the biggest things that I try to encourage, parents to do, and I recognize, the more children that, you may have, the harder this becomes, the more challenging this becomes, but carving out time once a week, special time with each individual child, whether that's 5 minutes, 10 minutes, 15 minutes, where they know that they have your undivided attention, right? And nobody else is going to bother you. And they are in those 15 minutes, they are the center of your world, right? And it should be, kind of focused on an activity, right? Like you're, going for a walk, you're going to go do something together, something that you both enjoy, really directed by the child. And again, it's really about building a relationship with your child so they feel like you're on their side, you're on their team, and that if they needed something, they needed help, that they could trust you to help them. I think, for people, let's say, who are involved, in schools and other groups, youth groups, right, kind of involved on that level, it behooves us to consider, what can we do to reach more people, right? How can we create a better resiliency? Can we teach things, like mindfulness in a school setting? Mindfulness is something that has great evidence to show its effectiveness. Relaxation techniques, stress management techniques. Can we incorporate this into, our health education, right? So again, we're trying to reach children in creative ways because we just recognize that there is an emergency going on, right? And we need to be creative.
That's really concrete. I think that's a great answer. I love kind of concrete takeaways like that parents can do. Again, I find that super reassuring because we're all sort of, or at least all parents, I think right now are facing very similar struggles and trying to find ways to connect with kids and sort of like dealing with their own struggles in the pandemic. And I think really, really helpful to have opportunities to connect with kids, to sort of give the kids an opportunity to talk about what's going on and maybe learn stuff about their children that they otherwise would not have an opportunity to know. So we covered a lot of ground today. Any major takeaways, anything that you really want parents to kind of like walk away from this knowing or being empowered with?
I think one thing that we really only touched on, we didn't speak about that much, was substance use, right? And I think just being aware that it's out there, especially I think with marijuana or cannabis, kind of becoming more acceptable, becoming legalized in more and more states, and our kids really, kind of coming to think of this as no big deal. So being aware that that's on the table. And again, that goes back to, if you can have honest and open and trusting relationships with your kids, and you get to meet their friends, right, then it's much more likely that you're going to know what's going on. But what I tell parents all the time is that if you think that you're doing something that your kids don't know about, forget about it. That's ridiculous. Your kids know everything. But your kids may very well be doing things that you don't know about, right? And so kind of having that recognition that, yes, the things that we do and we say are going to impact our kids, whether it's drinking, whether it's whatever it is that, we're doing, let's say in the substance use area or in other areas, right, where we think, oh, this doesn't impact my child, your child will know about it. But in order to know what's going on in your child's life, you really need to develop that relationship, right? And that's not that type of parent-child relationship. Yes, your pediatrician can help you, maybe go to a family therapist, or a psychotherapist or a psychiatrist, but it's really on us as parents to develop that warm, loving, trusting relationship we have, to have with our children in order for us to be there for them when they need it, in order for them to come to us when they need it.
Fantastic. I would probably have a whole nother separate hour-long discussion on substance abuse and the risk factors, right, of like how that can sort of spiral into true mental illness and dysfunction, and how maybe social media and all of that and access to social media plays into that. But I think this was good for our first hour. So thank you so much. This was fantastic. I really, really appreciate it. This was great.
Well, thank you so much for having me.
Sure.
Make sure you like us on Facebook and follow us on Instagram and Twitter. Thank you for joining us on KidzDocTalk.